And what I'm going to do here is I am going to activate the heated plugger. I'm going to continue to push down, and then I'm going to activate the heated plugger very quickly, and I'm going to pull it out. And you can see here I've done the most annoying thing in warm vertical technique is I've pulled the whole GP cone out. Welcome for this week's clinical case, and you are in for a treat today. A lot of the times what happens is every single root canal I ever do is always recorded, bar the times when the patient refuses permission. And sometimes when you're doing a root canal, you can feel the magic happening. So this is a really, really, really satisfying case, and it's got lots and lots of learning points in it. And basically at the end of the appointment, obviously I get consent from the patient before we do anything at all. But at the end, I say to the patient, you've got to let me use this because this is a fantastic case. And this case essentially just demonstrates probably the most annoying thing that can happen when you're using a warm vertical technique. And what I mean by a warm vertical technique is that essentially what I'm doing is I am placing a matched cone to the apex of the tooth, so the end of the tooth, and then I'm going to use a heated plugger to remove the vast majority of this matched cone, maybe 5 to 10 millimeters away from the apex, and then we are going to backfill the rest of the canal space with warm gutta perca. And I use these cases, I use this technique sparingly because I'm usually a single cone type of guy using the bioceramic sealer. But I feel like in this case, at the time, the canal space was really, really wide, and sometimes using bioceramic sealer when really, really wide open canals, in my experience, maybe not on others, it can be a little bit difficult because you're either overfilling the canal space, so you're overcompensating for the size of the canal by overfilling the canal, and then what happens when you push your GP cone to length? All of the bioceramic will go out the end of the tooth, and it looks awful on the X-ray. Not to mention the prognosis may be poor. I don't know. Or sometimes when you just don't put enough bioceramic down, then you get loads of voids. But what I would say is before we start this fantastic case, I just want to point out that when we look at the analytics of the videos, I notice that up to 2/3 of the people that watch these videos are not subscribers. Probably one of the most easiest ways to support the channel is to just hit the subscribe button. If you could hit the subscribe button, it takes half a second just to hover your mouse over the subscribe button, just give it a little press, and it's free. And I promise if you hit the subscribe button, every video that I upload every week will just get better and better and better, and it really spurs me on. So thank you for hitting the subscribe button. So if we look at the case, it's a case of an upper left one. And this was actually an internal referral. So I work in a few practices, and this was a referral that was referred to me by one of our resident dentists, and he doesn't do any root canals at all. So if you're a root canal dentist and you work in a practice where people hate doing root canal, fantastic, because you'll just hoover them all up. And sometimes, I know his nurse really, really well, and he did a root canal once, and she was almost shocked into a coma when he said he was going to do one. So in this case, also the referring dentist had thought that it was the upper left 2 which was causing the pain. And again, this is another shout out for doing consultations. I get a lot of referring dentists who just mither me to go straight to treatment. But what's really, really important is the consultation appointments. It's 30 minutes. The patient pays, by the way, and you get them in and you just confirm the diagnosis. You also talk about the costs. You also talk about the risks. And in the end, basically what you're doing there is you're gaining consent, and that's probably the most important thing to do in root canal. It is the most important thing because the amount of times I do a consultation and the patient just thinks, well, that's not for me. And you know what? if you've caught someone at that point and you've laid it on the line for them and then they say no, you have avoided a massive heartache if it all goes belly up. So in this case, I spoke to my colleague Will Hodgson, and he suggested that maybe the upper two was the culprit of this pain. And I suppose if I annotate the periapical radiograph here, I can kind of see that maybe there's something going on at the end here. But I wasn't too sure. The special tests that were carried out were inconsistent, and again we were really unsure about the issue with this case. So what I did do, unusually, is I took a cone beam CT scan. So when I say unusually I took a cone beam CT scan, I actually take a lot of cone beam CT scans, but I don't often take a cone beam CT scan to confirm pathology or pathosis. And usually what I take a cone beam CT scan for is just to map out the canal space, or to plan apical surgery, or to look for why root canal has failed. And in fact, when we look at the cone beam CT scan in this case, you can see that there's an obvious area around the upper left one, which is incredulous when you think about it, because when we look back at the periapical radiograph, you can see that there's no obvious area. So it's really important to use periapical radiographs and cone beam CT scans, but you got to read between the lines. Again, I've said this many times before, dentistry is a lot about nuance and sort of using your experience and not going down any kind of rabbit holes. So we move over to the case, and you'll notice here I don't have rubber dam on this tooth yet, and that's because I have to access through a crown. So it's really important that when you're accessing through a crown is that you can kind of see the whole tooth, and sometimes when you put a rubber dam on, you can't see that kind of angle where the root is sort of going. And if you access a crown, sometimes with a rubber dam, you've got a significant risk of perforation. And in fact, in this case, we accessed it really quickly. We just felt for that drop. And as soon as you open up the access cavity, you're going to put the rubber dam straight away. Again, I've said before, no rubber dam, no treatment. And sometimes you get these anterior clamps, and there's quite a sometimes it doesn't seal the rubber dam tightly against the tooth. So what's important is we seal it off. I use this light cure rubber dam sealer here, and obviously when you're using all your irrigants and things, it's going to be confined to the rubber dam, and it's not going to sort of freak the patient out when they taste that kind of swimming bath taste. And again, I'm at first using a fast handpiece to open up the access cavity, but sometimes this can be quite unsafe, and it can also remove more tooth tissue than it should. And in this case, what I'm doing now is I'm moving over to an ultrasonic, a diamond tipped ultrasonic. The problem with these ultrasonics is that they make an awful noise. So it's like a kind of a scratching your nails down a chalkboard kind of noise. So you just kind of warn the patient before you use it. But these are fantastic. You've got lots and lots of control over the tooth tissue removal. And then we're going to just irrigate the tooth and activate, because it's quite necrotic inside this canal space. And we know the canal space is quite wide, so I'm going to go straight for our working length with the apex locator. In this case, I'm using a size 15. The problem, of course, is that this is a metal ceramic crown, so you've got to be careful not to touch the hand file on the sides, because then it can cause a zero reading. And again, we're just very gently pushing it to length, pushing it through the apex, back out. We're going to adjust the rubber stopper, and then as we pull this size 15 K file out, we can see that the zero reading on the tooth is 22 millimeters, which is within the kind of normal range of these types of teeth. And then you'll notice also that I dropped into this canal space really easily. So I'm not going to waste any money or time on the glide path files. I'm going to go straight up with my master apical file. And this just goes to length really nice and easy. Lots and lots of irrigation. And we're 10 minutes in. We've shaped the tooth, we have irrigated the tooth, not finished the irrigation, but we've usually, this takes a long time, but we've absolutely motored along. But don't let this lull you into a false sense of security, because I would say usually with centrals, if you've dropped in really, really quickly, you're going to have a problem with obturation. You're going to have to, you have to be really, really on your toes with respect to obturation. My nurse is now just going to set up some GP cones, and she's going to give me a selection, and I always keep the GP cone box open because I just go through GP cones like they're going out of fashion, and I always inspect the end of these GP cones because I want to have a really accurate kind of ending. And when we look at these GP cones really, really closely under the microscope, you'll notice that the bottom GP cone here doesn't really conform to this kind of nice gradual taper. And clearly, if your GP cone doesn't have a nice gradual taper, or it's got an unusual end, or of course the GP cone isn't the correct diameter right at the tip, you can have problems with obturation. And it goes without saying that problem with obturation, you're going to get voids, you're going to have bacterial sort of proliferation, and you're going to get failure. Okay. And what I'm going to do is I'm just going to check for the cone fit. And you'll notice here, what I haven't done is I haven't measured this GP cone. I'm just going to push this to length until I can feel that kind of sort of snugness at the apex. And I pull out the GP cone. And this is kind of like a blind test. I know if we're at the correct length. And actually, when we pull this out and we measure it, we're actually short. So in the first instance, when we're short, what I like to do is like to go back to basics. We're just going to reshape the canal. So we're going to re-irrigate the canal, and then we're going to get our master apical file, and we're just going to shape this out. And you'd like to think that the inside of the canal is nice and round, but usually with these large canal spaces, they can be oval, or they can have unusual anatomy. So again, I'm going to recapitulate here with a size 15K file, and then we're just going to gently shape this out to the correct length. And then I'm just going to take a new GP cone, because I've noticed sometimes with these high flex, the GP cones aren't as accurate as we'd like to. And again, I'm not measuring the GP cone prior to pushing it in. We're going to push the GP cone to length so we can feel that kind of snugness at the apex. And then when we pull the GP cone out and we measure it, we're now at the correct reading, which is 0.5 millimeters away from the zero reading. So the zero reading was 22 millimeters. In this case, we've shaped up to 21.5 millimeters. So we're going to do our cone fit radiograph. I'm just going to place the GP cone to length, and when we have a little look, the cone is at the acceptable level. So this is looking nice, and again, as I like to say, we're just motoring along here. In this case, when I take a periapical radiograph, I don't like to use an endo holder, so I don't like to use a specific endo holder. I think it just gets in the way. And when the nurse is developing that radiograph, what I like to do is I just like to set up the tray for obturation because it's nice and efficient. We're going to get our backfill unit out, and this is a B&L unit. And then I am going to fill one of the wells up with sodium hypochlorite. This is going to disinfect our GP cones, because remember, the GP cones aren't sterile, they've just been sitting in a box. And then I am going to fill another well with EDTA, and this sort of removes the smear layer from the shaping, and then I get my heated plugger out. And also the sealer we're going to use is a resin-based sealer. You can't use bioceramic with heat because it denatures it, and it also it desiccates the tooth, so the bioceramic is less likely to set. And then we're going to just remove the GP cone. We're going to place this GP cone into the hypochlorite, so that GP cone now is all cleaning nicely, and then we're going to do our final irrigation protocol. In this case, we're going to use sodium hypochlorite as our first wash, activated nicely, and we're going to do a few cycles of that. Once we've used the sodium hypochlorite, we're going to move over to the 17% EDTA. Again, that's going to open up all the tubules, and then our third and final irrigation step is going to be sodium hypochlorite. The sodium hypochlorite is going to flow into all those little nooks and crannies. And the final sort of step before we obturate is we're going to dry it with paper points. I'm going to make sure that the canal space is super, super dry. And, you know, we had a case this week that we'd finished off, and I'd seen the patient for 5 appointments because we couldn't get the canal dry. So it's really, really important not to just obturate willingly. You want to make sure that the canal space is super, super dry. And in this case, you'll notice that it's taken me quite a few paper points to get the canal dry, but we did eventually. Another irrigant that I forgot to get out initially was isopropyl alcohol. Again, I've taken some advice off a few of the members here, where when we remove the GP cone, it's still going to have the sort of elements of sodium hypochlorite on the cone. So the isopropyl alcohol kind of removes that sodium hypochlorite, and then we're just going to air dry the GP cone, so it's really, really nice and dry. Now it's ready to be placed into the canal. We're using interlocking tweezers, so I'm just going to lock that in, and I'm going to place this GP cone in the interlocking tweezers, ready to go. And then we're ready to mix our resin-based sealer. Again, it's not the end of the world if you mix this too early, because the resin-based sealer takes quite a while for it to set. Because we're using a warm vertical technique, I don't want to place too much sealer onto the GP cone, because when you place this GP cone to length and then you use heat to condense this right down, what you'll notice is the GP cone will push really strongly to the apex, and you'll get a massive extrusion of resin-based sealer, which isn't great when it's setting out the end of the tooth and cause post-op pain and possible failure. So this is my first attempt at burning off the cone. And what I'm going to do here is I am going to activate the heated plugger. I'm going to continue to push down, and then I'm going to activate the heated plugger very quickly, and I'm going to pull it out. And you can see here I've done the most annoying thing in warm vertical technique, is I've pulled the whole GP cone out. And really, it's at this point you're thinking to yourself, what do we do next? Now, if you've got massive cojones, if you've got huge balls, you just put that straight back in. I have done that a few times, and I've got away with it a few times, but on occasion I haven't got away with it, and it's looked absolutely awful. So I would say, especially in a really tight canal space like this central, I can't really see where this cone would sit if I did place it back to length. So in this case, what I'm going to do is I am going to get a new GP cone. I'm going to inspect the end to make sure that it looks okay, and I'm going to give it a little bit of a disinfect, and then I am going to measure it, and then isopropyl alcohol, little bit of drying, and then I'm going to push it to length. And again, this is also quite risky, because you're obviously not taking this cone fit radiograph with this particular cone. But as I push it to length and I measure it again, I can see here that I am at the correct length. So I'm relatively happy with this. And in this case, what I'm going to do is I'm going to try a different tack. So in the first instance, what I definitely didn't do is I didn't measure how far I was pushing down the heated plugger. And this obviously can cause sometimes difficulty. And also what I'm going to do is, before I do my final compaction and my cut-off, I'm just going to remove some of the excess further up the canal. And this is less likely to get snagged when I finally do remove that final sort of obturation. So you can see I'm going to measure the heated plugger about 5 to 8 millimeters as if it would be from the end. And I am going to condense the heated plugger up to and around this kind of mark, and I'm going to hold the heated plugger off, and I'm going to push down. You can see I'm moving the patient's head. I'm going to do it for about 10 seconds. I'm going to just activate the heated plugger very quickly, turn, twist, and you can see here now that we've gone from the most annoying thing in one vertical compaction to the most amazing thing. Look at that, looks absolutely gorgeous. So we know that we've got a nice plug of GP there, and as I sort of condense this plug down with my Mac 2 plugger, we can see that some of that sealer is sort of leaking out, and we can see that that's obviously sealed the end of the tooth really nicely. So don't be shy. We know we've gauged the apical end, so you want to just make sure you condense that really nicely. you know, I suppose in one case you could take an x-ray to check, but I'm happy with that. And then we're ready to load our backfill units. I use these B&L unit because I think it's cost effective, and also I've used it for many years, so it's good in my hand. But these little pellets, you can kind of just they're really cheap, and you know, you can just use them for each patient, and you know cross infections perfect in this case. The problem with elements, of course, is you use those tips. You know, some people will argue you need to throw them away, and they're quite expensive, and you can't use them between patients. So I'm just going to remove some of the excess of that warm gutta perca, and then I'm just going to backfill it. Sometimes I like to backfill a little bit and then push it down, and sometimes I just like to backfill it all the way. In this case, I feel like I'm pretty confident I can sort of backfill this canal space all the way to the end. And what I'm going to make sure that I backfill only up to the CEJ. And then when we look at the x-ray, it just looks absolutely phenomenal. It looks fantastic. So I'm really happy with this case. And probably the most annoying thing about this video is that when we took this post-op radiograph, I always turned the video off in between just to save on data, and I forgot to turn the video back on to show you the final restoration. But what we did in this case is I sealed off the end of the GP with Vitrabond. The reason why I did that is sometimes it's really difficult to get your etch and bond so far down the access cavity and for it to set properly. So the Vitrabond kind of seals off the cavity, and it's easy to place if you're using the correct tips. And then once I've sealed off the GP with the GIC, I'm just using a bulk flow composite, which is STR. And overall, you know, this is probably one of the best videos I've done in ages. I was really excited about this. You know, the patient was fantastic. The case was great. We did something annoying, but we overcame it. And that's all what dentistry is about. Because, you know, if you came to work and it was dead easy, you'd probably hate the job completely. It's always about this kind of, you know, finding problems and overcoming problems make you want to come to work, and it makes you really excited about the job. And thanks for watching. You know, again, like I said before, if you really like the channel, please like and subscribe. Please subscribe. It's super free. And if you really like the channel, you can become a member. The membership program is a small monthly fee. You get to support the channel, keeps me independent, keeps me doing these videos, and also I run usually 2 to 3 weeks ahead with my videos. So if you just can't get enough and you want to see the videos quicker, then the members have got early access to those videos. And overall, I'll see you in the next video. Bye bye.